Well, good evening, everybody. Really an honor to be with you. But Dr. Wyckoff, I need you to stay up here for just a minute. So here I am, actually at the lectern of Leading Voices, and as Dr. Wyckoff mentioned, I've been out in the audience many a time, and have always really enjoyed it, and always appreciated what Dr. Wyckoff brought to the region and to the college. And when he asked me to do this, one of the things that I didn't mention to him that I reflected on was the fact that probably 6 or 7 years ago, I asked him a favor. And that favor was, would you come to the Cumberland Plateau Health District in Southwest Virginia and give my team there, another terrific team of public health workers, a keynote about public health in the United States and your perspective on it. So he very kindly did that. Now, let me tell you that lecture was in Buchanan County, in Grundy. And I remember it, and I remember thinking, it's only about 2 hours, no, maybe it's about 3 hours away. And he did. He dutifully came up and delivered, I think, a brilliant presentation. And I've always appreciated that. So here I am at ETSU in Johnson City, back in the neighborhood, if you will. And I'll note that I think I'm a little bit further from where I live now, Nashville, than he is from Buchanan County. So I think I've got a little bit of an edge there. So I'm glad about that. But there's one other really important thing I want to mention. This is about leading voices in public health. And Dr. Wyckoff has been a leading voice in public health, both nationally and certainly in our region. And I was really thrilled when I remember getting his bio card in the mail. And I remember sitting at my desk in Russell County and getting the bio card and being very impressed and thinking, well, this is really neat to have somebody with his experience, dating back to his time as a local health director himself, come to an area like this to teach public health. And one of the things that he did that I've continued to appreciate and that has had an impact, I think, on public health in our state is a very simple and creative act, and he's good at that. Some of you probably noticed he's good at acronyms. And he did this simple button. And I think the first time I saw this button, it was a 48 with a line through it. And here we are, many years later, with a 39 with a line through it. And our vision in Tennessee and in the Department of Health is to one day be able to have a button like this that has a 10 with a line through it. If we continue to work the way we're working, if we continuously improve our organization, if we continuously work to enhance primary prevention, I think we can do that. But I've had you standing up here for too long. But what I want to say is, but you got to come up here, okay? He is an outstanding public health leader, and I just wanted to take the moment to recognize him in front of his students and many of the staff. And President Nolan, I think you're here. President Brian Nolan of ETSU, there he is in the back. I want to recognize Dr. Randy Wyckoff, the Commissioner's Award for outstanding service to public health in the state of Tennessee. Thank you. So, and Dr. Nolan, I really appreciate you being here tonight, and I just want to say welcome to our region, and I really appreciate the fact that what I've seen is that you're continuing to increase the presence and the footprint of an important regional university for this region. And we all know this is a region. We know that there's this pesky line to the north of us and to the west of us in the east that kind of divides different geographic localities. But when it comes right down to it, we talk about one world, one health. Certainly, we've recognized in this region for a long time that it's one region, one health. And I really appreciate the fact that you're advancing that mission here in the Tri-Cities. So thank you. So it's my honor tonight to talk to you about an evolving crisis, one that in fact continues to evolve. The The quotes on the cover slide: one of the most shocking outbreaks in the annals of American medicine, the largest healthcare-associated fungal outbreak ever reported in the United States, I think are two phrases, two quotes that summarize it well. But here is a starker slide, and one that we should understand. So even as I speak to you here tonight, we have 13,534 people across our country who are still suffering with the uncertainty engendered as a result of exposure to this contaminated medicine, called many times in the popular media moldy medicine. It's an apt description. 733 people were sickened, made ill by this, and 54 have lost their lives. Many people around the country are still being actively treated. In fact, most people are being actively treated for this infection, either as a result of the initial meningitis or later as the epidemic evolved and we had a better understanding of it and we were able to catch it earlier, localized infection. And this continues to be an extraordinarily challenging disease to treat. We don't have any historical data on extraohylum infections in human beings. They're extremely rare. We have still the CDC sponsoring regular meetings of an expert panel of mycotics experts, infectious disease doctors who specialize in mycotics, that are world-renowned for their knowledge in this area, who are assisting clinicians, and there are several clinicians in the state of Tennessee and around the country that are taking care of many of these patients. And the families and the patients are suffering with this situation. So this is just something we have to remember. And this is an intentionally blank slide, and I'd like to ask you just to bow your heads with me for a moment of silence for the families and the patients and the people that continue to suffer with this problem. So thank you. So this reminds us that this is about people and lives, and this is the first lesson, and we can't forget this lesson. This is about people, their lives, the dead, and those they leave behind. This is really what we in public health work to prevent. So I wrote a few things down, and I'll let you look at a few pictures as I mention these things. I want to paint a picture of an event that continues to evolve, a never event. Sadly, never events occur daily in our healthcare sector. By some estimates, more than 8 a day. This never event, the contamination of a medication and its introduction into a sterile space, was and continues to be, as we've said, disconcerting and catastrophic to thousands of people. The event was a failure of prevention, a failure of primary prevention because the illnesses that occurred should never have been in the first place. We can do better. In our present culture, we focus on cure or mitigation and care rather than prevention and health. This is costing us $2.6 trillion a year, about 18% of our gross domestic product in the United States, more than the gross domestic product of the entire United Kingdom. And it's buying us a health ranking of 17th out of 17 developed nations, according to the National Research Council, the Institute of Medicine, and 37th in the world, according to the World Health Organization. So the key is to understand that if what we're incentivizing is care, what we'll get is care. If we incentivize health, we have an opportunity to get health. We can do better. The ongoing question is how we prevent these never events and serious events and the more common near misses and precursor events. In the health sector, we're beginning to look seriously at this, but we have much to do. This near event fungal outbreak, this never event fungal outbreak, is also a sentinel event. It's already prompted changes, improvements, and a new understanding that we have to do better in the balance between meeting daily demand for vital and often shortage and scarce medications, and the absolute safety in meeting that demand that every one of us expects and relies on. Even though I wish that this has never happened, and I do, I'm very proud of what we did. I'm very proud of our team. Together, we made the difference. We again proved the value of public health. But unfortunately, the public usually only sees this when things go wrong, as they did in this case. They never see all the precursor events that don't happen because we were there to prevent them. I have a movie that I'm particularly fond of. My wife, Dr. Janet Dreyzehner, who's in the back there with me tonight. Hi, honey. We like to watch this movie every year, and I confess we don't get to do it every year, but it's always a treat when we do it. It's a movie called It's a Wonderful Life. And it's a favorite movie of mine on a number of levels. But if I had one wish for public health, that wish would be that we had an angel like Clarence who could give us the gift of the world getting to see, just for a time, what the world would be like without public health professionals. Now, I would want that to be undone at the end like it was in the movie. But if the world could see what it is that you as public health professionals do every day and what would happen if you weren't there, it would be startling. So, tonight, I want to look at how public health made a difference that many are able to see and appreciate. So this began and ended with a team. And you know, usually you save your acknowledgments for the end of a talk, but this talk wouldn't have happened without the team. And the team goes beyond the Tennessee Department of Health. If anybody thinks that we did this on our own, that would be incorrect. We could not have done it without the trust and the cooperation and the relationships and the goodwill of people around our state, clinicians, laboratory staff, infection control professionals, pivotal, affected clinics and staff. Of course, the Tennessee Department of Health and colleagues at all levels. The Tennessee Poison Control Center, they operated our crisis line. The Centers for Disease Control and Prevention, critical federal partners, the Food and Drug Administration, the Massachusetts Department of Health, other state health departments, and our political leadership, Governor Haslam, our legislators, and my administration colleagues, commissioners that reached out to me, that offered any assistance that they could provide. And I'm also going to begin with the end in mind, mention the key lessons. Communicate, communicate, communicate. Can never do that too much. Much of the success that we had in addressing the early stages of this outbreak centered around communication. And I'll talk more about that in a bit. Pre-existing capacity, plans, and trusting relationships are key. It takes time to develop these. It takes time to create them. It doesn't take nearly as much time to lose them. One of the things that I'm particularly fond of in our area, and Gary Mays is here today, I see, from Sullivan County Health Department. He was kind enough to take on the role of the chairman of the Mountain Empire Public Health Emergency Coordination Council that I sat on for many years here in the Tri-Cities, and that was all about trust and relationships and building communication. So we knew each other in a time of crisis, and we would be able to do what we needed to do to protect the public health in the region. Good to see you here, Gary. Public health is a team sport. It's a team sport. And I like to remember that public health professionals are exceptionally resourceful, passionate, dedicated, caring, and eager to make a difference. We have to trust this, and we have to act on it, whatever level we function at in public health. Just to remind you and remind us that there was a background here to this outbreak. It just so happened, for reasons that are not clear, that there was a number of different types of meningitis events that were being reported, particularly in Middle Tennessee, at the time that the outbreak surfaced. On the 10th of September of 2012, unfortunately, a young man died as a result of an Neisseria meningitis, necessitating the prophylaxis of more than 1,000 college students at Middle Tennessee State University. Good idea to get your meningitis vaccine if you're in a risk group, but particularly if you're entering college or you're a military recruit. I have my meningitis vaccine. I'd recommend it for most folks. But it got certainly the community to understand the risk involved in this and created a lot of anxiety. On the 20th of September, there was a letter to parents in a Williamson County elementary school because there had been 4 cases of viral meningitis detected in the school. And then on September 28th, in the process during the time we were in our initial investigation of this outbreak, a child was reported to have died of pneumococcal meningitis. This was the email that started it. This was supposed to be a video, a brief clip of the first press conference that we did 14 days after we received that letter. That's not available, but you'll see some clippings later on. But following that initial public discussion of this tragic outbreak, there was a significant amount of media interest on a regular basis. 23 states were affected by this outbreak because the contaminated medication, the methylprednisolone acetate, was shipped to 23. Ultimately, only 20 states have seen cases. So let me go and read this message. Tuesday, September 18th, 1:50 p.m., messages to Dr. Tim Jones, our state epidemiologist. Dr. Jones, we have a case of an immunocompetent man with Aspergillus fumigatus meningitis. He has been receiving lumbar epidural steroid injections at an outside facility, which is the only explanation we can find to explain this. He also has an L4, L5, 1 centimeter epidural abscess which supports this theory. I wanted to inform you of this case in case you feel that an investigation is warranted. I am happy to discuss it further if you like. And it's signed April Pettit, who is an infectious disease clinician. She was one of 2 Tennesseans named by the Tennessean newspaper this year as Tennesseans of the Year for her work in the initial detection of this outbreak, the other one being our own Director of Healthcare Associated Infections, Dr. Marion Kainer, and you'll see some pictures of her later on. So within 48 hours of this report, we had confirmed exposure of the index patient to the epidural steroid injection. We had contacted the CDC. We had identified 2 additional cases, now a cluster in Tennessee. The clinic had voluntarily closed. We had identified the suspect medication, again, the MPA, methylprednisolone acetate, a type of medication that's a steroid that's used in a variety of applications, in this case, an epidural steroid injection. It's important to point out that at this stage, we really did not know that that was the ultimate associated and proximate etiology of the outbreak. We were concerned about the clinic itself. Were there elements in the environment of the clinic, for example, water damage that might have created mold in the clinic that could have contaminated surfaces or contaminated sterile needles? Was the contrast media that was being used potentially contaminated? Was the lidocaine potentially contaminated? What about the needles that were being used? What about the surgical tray that was being used? We really didn't know at this phase, but we had identified that as one of the suspect medications. We had also traced it to a compounding pharmacy, New England Compounding Center, which is now well known. And we had, out of an abundance of caution at that time, sequestered supplies of MPA and other supplies at the clinic, and as I mentioned, they had voluntarily closed. Within 72 hours, we had an on-site evaluation of the clinic processes, actually made 2 site visits to the clinic to assess the environment of care. We had identified additional potential cases. We had notified the Tennessee community through our Tennessee Health Alert Network, the THON, and this was the first of several alerts that went out before the first press conference on October 1st of last year. And of course, that first THON was a report of meningitis following epidural steroid injections and a call for cases. Are there any other cases out there? And the CDC had confirmed for us at that point that they had detected no cases from other states, although in retrospect, very likely cases were occurring. Within 8 days, we'd worked with the clinic to begin contacting patients possibly exposed to contaminated medication. As a result of a conference call with the Massachusetts Department of Health, the Board of Pharmacy, the CDC, and NECC, all of whom were cooperating at that time, as a result of the information that we had gathered, some of the initial data analysis, the epidemiology that we had done, and our concerns about contamination in the medication, NECC agreed to voluntarily recall 3 particular lots of methylprednisolone acetate. Remarkably, these were the only 3 lots that were ever definitively associated with the outbreak. So what was the public health outbreak of these initial, or rather, what was the public health impact of this initial response to the outbreak in Tennessee? Because of pulling the contaminated steroid, we believe that 368 patients were not exposed. So those 368 were not added to that 13,500 that you saw at the beginning of the presentation. Applying the attack rate that we determined in Tennessee, we determined approximately 99 cases of disease were prevented. And applying a 31% case fatality rate, which was the rate that we saw before October the 3rd, we determined that we probably saved approximately 69 lives. This is a slide that appeared in a JAMA article, and what you'll see there is a dramatic decrease in the 30-day case fatality rate by week of diagnosis following the identification of this outbreak and more aggressive active surveillance and a better understanding of how to initially approach treatment. This also is illustrative of the impact that the initial public health detective work and epidemiology and outreach had. And we'll talk a little bit about the active and aggressive outreach in a minute. But you see there a bimodal curve, and the initial cases were mostly meningitis. In fact, some of the early cases presented as stroke. And we hypothesized that the earlier signs of local infection were not detected because, of course, these patients were presenting for epidural steroid injections because they had some lower back pain. Very difficult to distinguish pre-existing back pain from an accentuation as a result of a small epidural abscess. The initial presenting symptoms for this meningitis were not necessarily typical of a bacterial or a viral meningitis in terms of their severity. Often presented with very mild headache. In fact, in some cases, there were no symptoms, and so these folks progressed and had basal strokes. And it's quite possible because of the, one could speculate as a result of the median age of this patient population, had an astute clinician not reported that aspergillus meningitis, which continues to be a little bit mysterious because that turned out not to be the contaminant, a major contaminant of interest, although it certainly could have been a contaminant. These strokes could have gone unrecognized for quite some time, and we may have seen much more of an impact around our nation. The other thing you'll see is that the second peak of mostly localized infections. Now people are starting to understand what symptoms to look for, and we're engaged in screening. The single most important diagnostic test in this outbreak was a lumbar puncture, not a particularly comfortable procedure. And something that unfortunately people that have been victims of this preventable tragedy have had to undergo repeatedly. Within 10 days, we had the first preliminary results from the cohort study that implicated MPA, and we had determined through an analysis that there did not appear to be any clinic factors. The CDC put out a call, an EpiX call, 4 cases. Again, this is all prior to public release of this information, but at this point, many people are aware of the outbreak, and certainly the medical community is well aware of the circumstance, and infection control practitioners around the state. And very importantly, because of the work that we had done, a second state, North Carolina, detected a possible case. Within 14 days on October 1st, we had our first press conference that was called in our conference room at the Tennessee Department of Health. And we determined that it was very important that we lean forward in our communication posture. We had press briefings daily, either in person or by conference call, either myself or several other spokesmen. Active outreach to expose patients, and that had been going on prior to this discussion with the media, and completion of the first epidemiologic studies. At that point, we still weren't certain of the etiology, although we strongly suspected the MPA. The multi-state investigation was underway, and many agencies now across the nation are involved, including the CDC and the FDA, although I don't believe they had their first media briefing until several days later. And that was the paper that resulted the next day. Day 17, October 1st, a few days after the first press briefing, the FDA obtained vials many from supplies that we had sequestered, and identified for the first time fungal contamination by direct microscopic examination of a sealed vial. So they unsealed the vial, put it under a microscope, and said, yes, here we see fungal elements. So they confirmed that, in fact, the vials themselves were contaminated. Until that point, we didn't know that. We had an association, we had an epidemiologic association of exposure to the medication, and we had what we thought looked like a dose response, but we didn't have confirmation that there was actually a biologic agent contained in what was supposed to be a sterile vial. This is a communication, another Tennessee Health Alert Network report, and these go to hospitals and providers all over the state. And this was our advice once we determined the contamination and learned of some of the conditions at the facility, which were quite disturbing, which is probably an understatement. We advised clinicians around the state to cease using NECC medications and products. You see there it says cease use of all medications and materials from New England Compounding Center. Although our State Health Operations Center had been open as a workspace prior to our opening it formally as an emergency operations center, and we had some visitors from the CDC assisting us with data abstraction and the actual cohort studies that were being done. On that Friday, we opened the State Health Operations Center, and that was significant for 2 reasons. It brought more resources to bear on this evolving crisis, enabled us to track cases better, to coordinate with our regional health operations centers, and it helped us engage in active surveillance. And that's where the greater body of public health workers and professionals around the state became engaged. Public health nurses, both in the Tennessee Department of Health and in our Vital Metro partners, were engaged in actively creating relationships, calling, seeking patients. We had worked very hard to contact patients through the clinics, but had not been successful in definitively contacting all patients at this point. And following the operation and opening of the shack, we redoubled those efforts. It's just a few photographs of what the State Health Operations Center looks like, and what you see when it's underway. There were 3 clinics in Tennessee that received contaminated lots of methylprednisolone acetate from NECC, and the 3 contaminated lots were known by the dates of their first production: the 521 lot, the 629 lot, and I believe it was the 810 lot. By the time this outbreak was detected, almost all of the 521 lot had been used. And in fact, ultimately the FDA was only able to test 17 of those vials, and they detected minimal contamination. But it's believed that through the Epidemiological Association there was contamination at that time. 629 lots were available for testing, as were the 810 lots. As a result of the engagement of public health professionals around the state, we had two very resource-intensive outreach efforts to all exposed individuals in the state. I also should mention that the people that were exposed were not merely residents of Tennessee. In fact, there were people overseas that had received epidural steroid injections at one of the 3 clinics in Tennessee. There were people, many people actually, in the triple digits in a border state that had received epidural steroid injections in Tennessee. Their numbers are actually counted in the Tennessee case counts by the CDC convention. But we worked very hard to identify these individuals, literally knocking on doors, going into gated communities, and in one rather remarkable case, one of our public health nurses actually tracked down a person on a bus in a national park out west who had a headache. At that time, it turned out that the headache was not due to meningitis, but it gives you an idea of some of the extraordinary efforts that were required to find people. But find them we did. And the secondary effort was an effort to alert them to some additional things they could do to protect themselves. I think one very important piece of this is the relationships that our public health nurses and our frontline clinic workers develop with these patients. So these people would call the Department of Health. They would speak to somebody at the front desk. Those are vital folks. They would have a relationship with a public health nurse, somebody that they trusted. And in this particular case, the State Department of Health had as much knowledge as anybody in the country as to the features, the clinical features of this disease, and what things could be done with respect to diagnosis and with respect to treatment. So we use that chain of expertise that went from people like our Chief Medical Officer, Dr. David Reagan, and our Director of Healthcare Associated Infections, Dr. Kainer, and Tim Jones, our state epidemiologist, and their teams, and the CDC experts. That chain all the way down to our medical directors of the various regional health departments and the county health directors and the public health nurses. So there was a continuous chain of information. And I think it was a very important thing to be able to have those relationships. And in fact, some of the public health nurses probably don't know I know this, but I know some of them are still calling and talking to those patients from time to time, and that's just fine. So they continue to suffer with this, as I mentioned. This is a joint effort between public health and the clinics, and let me emphasize again, the relationships were really important. Had the clinics, especially the St. Thomas Outpatient Neurosurgery Center, not cooperated with us in the initial investigation, we could not have done what we did. So that cooperation was essential. And I think something we all have to remember is that these clinicians and this clinic was traumatized as well, as were the other 2 clinics around the state. Their idea was that they were trying to help people with an issue. And one of the doctors I recall commenting, you know, I've done this thousands of times. I think the number he used was more than 30,000 times. The most I've ever had was a superficial infection. And he was just absolutely traumatized that one of his patients, and unfortunately many more, succumbed as a result of this issue. So the other I think important piece of this is that the relationships were ongoing, but we made a determination, you know, very frankly, not to be pests. So we had people that we communicated with, but when they felt, and we had a discussion with them, that they were ready to disengage, we would say, okay, well, you know, we won't call you again. We had some regular calling protocols where we call them in follow-up intervals, but some said, okay, you know, I understand what the issue is, and I know who to call if I need it, and then we disengaged. some people wanted to continue to be called, and so we continued with that. As the outbreak went on, as I mentioned, repeat calls occurred when we had new information, but those relationships were already formed. I mentioned communication. So we had an extensive and constant emphasis on communication. Two types of communication critical in addressing this outbreak. Internal communications, kind of the people who were working and working to understand this outbreak, and the external communication. So some of the internal communications I've mentioned, the Tennessee Department of Health and our metro partners at multiple levels, our sister agencies, the governor and his staff, our legislators, public and health partners, both around the state and of course our federal partners. And then the external communications, particularly patients and their families. And I've just spent a fair amount of time talking to you about the importance of those communications, and I really think those were foundational and critical. The impacted clinicians, both the clinicians who had been involved in the events themselves, and then the clinicians that were taking care of these patients. Some primary care physicians, some infectious disease clinicians who are now, unfortunately, world experts in this particular disease. Professional associations were very important, both in providing us feedback and getting important messages out. The broader medical and scientific community, and of course the media and the public. And I've said this before, I'll say it again. I thought the media did a really important job in providing us an outlet to the broader public, because as I mentioned early on, there was a lot of fear, there was a lot of concern when we first announced this outbreak, because all anybody heard was meningitis. Kind of like when a doctor uses the word cancer, we clinicians know that that's the last thing that they're going to hear, maybe until they come back for another visit. Well, the media, to their great credit, within about a 24-hour news cycle, correctly reported in most jurisdictions that this was a non-contagious, unique form of meningitis, not related to the other types of meningitis that people were concerned about. And it didn't take very long until everybody got the message. They did a really nice job communicating that. This is part of the internal communications, daily briefings, multiple times a day, phone calls, emails, but frequently getting people around a table face to face. That's really important. Certainly media coverage was an important part of the extensive communication efforts, and you see some photographs of that there. These are some of the media reports that came out over the time. That's the second briefing that Dr. Reagan did. I was actually here at the Sullivan County Health Department. I think we were talking about the academic health department, but I could be mistaken. That was day two. This got national media attention. Certainly, the local media was very interested in this. Just gives you a sense of the type of coverage and interest that was being generated. This was very important. We spent a fair amount of time putting together a scientific publication because we thought it was so important to communicate the results of the studies that we did to the scientific community, so people could have a better understanding of what to look for, and to put it in a peer-reviewed journal makes it actionable for the broader medical and scientific community. So the New England Journal actually solicited our team for this publication, and we published this online. I think it was on November the 6th. So something that we felt was a very important step to take to inform the broader scientific community in a rigorous fashion. And of course, informing key leaders. Leadership is extremely important to any difficult situation, and I really appreciate the leadership of Governor Haslam. A number of legislators called me and reached out to me and said, "Is there anything I can do to help you?" In a very real way, one of the wonderful things they did is they gave us the time and the space to do the things that we needed to do. And you see there Governor Haslam coming to visit the State Health Operations Center. That was another video. This is actually a video of Dr. Kaner testifying before the Senate Health, Education, Labor, and Pensions Committee, Senate HELP. And she was, to my knowledge, other than the interim Commissioner of Health in Massachusetts, she was the only public health professional, local public or state public health professional that was called to testify. I wish you could hear it, but the technology won't cooperate with us today. So again, lessons. A little bit of redundancy here. Communicate, communicate, communicate. It's a little bit like location, location, location. But I've never been in a circumstance, in any after-action report, whether it's for an exercise or for a real event, where we couldn't have communicated better. And despite our extensive focus on communication in this event, I'm sure that we could have done some things better in the communication. But that really is foundational to a response, and it's communication at all levels, bidirectional, up and down. Robust public health infrastructure is critical, including the authority to act quickly. Pre-existing capacity, plans, and trusting relationships are key, and as I said, it takes time and effort to put these in place. And they're relatively easily, if they're not attended to, they fade. People move on, people retire, people change jobs, the faces change, so the relationships have to be maintained. That's a critical part of public health capacity, and I think it's frankly a critical part of public health leadership. So leaders at all levels of public health really have to encourage the people that work with them to get out there, to show up, to know the people in their community, know the people in their in the spaces that they operate. That made all the difference in this investigation and in this response. Lean forward, try not to fall over. If you do, stand back up, dust yourself off, and lean forward again. Sometimes you do things that aren't traditional. Some people raise their hand and say, is that really our role? Aren't we really supplanting somebody else's role? I work hard not to do Me Too things. You know, as I mentioned before, we have this health sector, and we spend $2.6 trillion on it, and it's big. And 95% of that spend is on care. And one of our emphasis items in the Tennessee Department of Health is on prevention and primary prevention, not secondary and tertiary prevention, the kind of prevention that you know, healthcare providers like me are usually talking about when we're referring to prevention. But we recognize in the Department of Health that we are the public health enterprise. We are the governmental primary prevention enterprise for our state. And public health has to be the primary prevention enterprise for the United States and really for the world. And I spent a little bit of time in the Essentials laboratory today with Dr. Wyckoff, and I was just really struck by what a great program that is, because it is teaching students a lot of different lessons, group dynamics and how to think, but what it's teaching from a public health standpoint is that primary prevention works, and it's not always the obvious things. And I mentioned a few of this little example to a few of you when we were in the hallway not too long ago. You know, as I walked through there was a contraption. It wasn't really fully formed, but it was obviously a wheelbarrow. And Dr. Stutz pointed out to me that this was the invention of a class, and it's not just a wheelbarrow to save labor, but it turns out that in a particular community, one of the highest risk times for violence against women was when they had to travel to a water source, which they had to do 5, 6, 7 times a day to get water for their family. And that's when they were most vulnerable to assault. And by creating a wheelbarrow that enabled them to carry more water, they reduced their risk substantially down to a single visit a day. So, you know, who would think, without taking it back, that that kind of an intervention could save a family, you know, tremendous tragedy, even save a life. Start early, work late, but get some rest. Dr. Kaner famously slept on a mat in her office. She didn't have a condominium 2 blocks from the Cordell Hall building. But the get the rest is important. You have to stay sharp. And in a situation like this, we always have to think about sustaining the operation. This didn't go on for 4 days or for 2 weeks or even for 2 months. It went on for quite some time. Don't let the perfect be the enemy of the good. And I probably should have done these where you couldn't see it because you've seen this. Always have a crack team of experienced and well-led healthcare-associated infection epidemiologists at the ready. So no matter where you are as you go through life, always have those healthcare epidemiologists around. They can come in really handy. So that's that team. These are the faces of the people. That's Dr. Kaner in the inset. I'm pretty sure she's in the inset. Well, I put her in the inset, but I'm pretty sure she's not in that picture because I believe she took it. And that's her healthcare-associated infectious team. I mentioned this already. Public health is a team sport, and it really is. We can't do what we do without relying on the expertise of each other. I lived this investigation and this outbreak and continue to live its aftermath as we seek better solutions to having a balance between the need for medication and the shortage of medications and the need to guarantee absolute safety and sterility. But I don't have all the expertise of all the people on this team. And here's that team. Here's part of that team. This is just the central office team. We couldn't get everybody who participated in this response, directly participated in this response, together for a picture. And in addition to these folks and the people that directly participated in it, I always like to remind folks, that they also serve who sit and wait. So there are all kinds of people, our colleagues in public health and the colleagues of our partners who weren't necessarily at the pointy end of that spear at that particular time. But they stepped up to do all the other critical tasks that everybody is relying on them to do every day to free up the people that were working that outbreak. We have some capacity in public health, but this was absolutely a surge for us. More than 7,000 hours involving 180 people. And all those 180 people had jobs to do that weren't tied to this outbreak. So somebody had to step up and make sure that critical work, some of which can't be put off, got done. So again, a real team effort and a lot of unsung heroes in a situation like this, but I appreciate them just as much. Regulation is important, but will never assure right action by itself. As I mentioned in my opening comments, incentives must be aligned to achieve the result you wish to achieve. This is not easy. This is hard. Regulation, that's a part of a thoughtful system that incentivizes high reliability and is applied consistently across a sector is a good model. Think about the airline industry. Think about what would happen if the airline industry had 8 never events a day. Think about what would happen if the commercial airline industry had a never event a month or a quarter. It would have a significant impact. We have a long way to go in the health and healthcare sector. Respect and acknowledge the known unknowns. One of the known unknowns in this outbreak is how long is the tail of this infection risk? We don't have an answer to that question at this point in time. Certainly the period of greatest risk has passed. Certainly it's passed. But we don't know how long we need to treat people. There's only a few people that have been taken off treatment. This is difficult treatment. It makes them sick. Some people would rather take their chances than continue with the treatment. It's a medication called voriconazole. It's an antifungal. Some people are trying some different antifungals like itraconazole. But we don't know what the latency, or rather what the ultimate latency of this disease is. Probably for many people, the risk has passed, but we don't know who they are, and they don't either. That's the rub. And it's likely that we'll continue to see cases for many months hence, and it's likely, and unfortunately, we'll continue to see deaths. In fact, we had another patient succumb from complications related to their infection just last week. But also beware of the unknown unknowns, and that's one of the things that I think about whether I'm responding to an outbreak or I'm thinking about a new law or a new regulation. Some of you are familiar with the Prescription Safety Act of 2012. How many medical providers do we have in the room? So just thank you in advance, or thank you for what you're doing. I really appreciate the medical community, the healthcare community, stepping up to our substance abuse epidemic in Tennessee and agreeing to be a part of the solution. We know it adds some additional burden to your practice, whether you're a prescriber or a dispenser, but we believe it's the right thing to do. But importantly, that regulation sunsets in 2016 because we don't know for sure that it will do what we hope it does. Now, I feel pretty confident that it will have a positive result, but it might not be something that we need to do forever. So beware the unknown unknowns. Beware of unintended consequences. Beware of immediately reacting, to put a hammer down and not really being sure what the result will be. Because the unintended consequences are real, and sometimes they can be worse than what it was you were trying to prevent. So I wrote down my conclusion because I wanted to be sure to get it right. So today, all over the planet, public health professionals and partners will toil gladly and passionately countless hours to promote, protect, and improve health and prosperity. Through primary prevention, they will prevent the need for care and enable the fullness of human potential and joy. They will work to prevent precursor events so that a serious event or a never event, like the ones we reviewed tonight, does not occur. But there will be no one to report on these non-events because they didn't happen. Because these professionals, and there are many of them in this room, both professionals and those of you aspiring to be, and I congratulate you for that. Because these professionals, through real and deliberate sustained efforts, prevented these precursor events in the first place. They are the daily heroes of public health, and I'm honored to speak to many of you here tonight. But it doesn't end there. What we're doing in public health makes a difference, to be sure. But there's one more thing that is on us. We have to take on the root cause. We have to make the case for primary prevention and population health. We have to demonstrate that hoping for health and rewarding for care is not only not working, it's not working, but there's a better way. So I leave you with this challenge. We have to figure out a way to truly reward and incentivize the healthcare sector and all the rest of us towards health. We have to make primary prevention pay. If we can do this, then the cascade of events that led to this tragedy won't happen again. Thank you.
We have time for a couple of questions.
I have one.
Oh, yeah.
No, I'm just kidding.
Oh, okay.
Just for old time's sake,
Definitely enjoyed the presentation. I had a quick question. I know that the Tennessee...
You had 3 out there. This is 4. Okay.
I asked a lot of questions. I know that the Tennessee Department of Health has made some efforts to ensure that this type of outbreak doesn't occur from a compounding pharmacy here in Tennessee. Can you update me on those efforts?
So one of the things we have to understand is that professionals in the state are regulated by boards, and we have a board of pharmacy that is responsible for the regulation of pharmacies, including compounding pharmacies. Our department supports that board. We have about 350 people in the Department of Health in Tennessee that regulate 251,000 licensed healthcare professionals in the state and about 1,800 different facilities. So we rely on a combination of our administrative support and their oversight to do this regulatory work. Since October, we have 5 inspectors currently, 5 pharmacist inspectors. And I'm proud of the fact that our inspectors for our Board of Pharmacy are actually trained pharmacists. Many states don't have that capacity. But they've inspected about 137, if memory serves, out of about 246 compounding pharmacies that are currently compounding in the state. And those have been targeted inspections aimed at the higher risk activities, which I think is appropriate. You want to look at where the hazard control points are. The board, I think, has taken some positive steps. They have, through policy, created a sterile compounding modifier. Up until this time, we didn't make a distinction between a compounding pharmacy and a non-compounding pharmacy, if you will. But there's a really simple reason for that. If you think about what the symbol for pharmacy is, it's a mortar and pestle. So all pharmacists compound to one degree or another. But we now have a sterile compounding modifier, so we'll be able to identify those pharmacies that are doing sterile compounding. They've voted for creation of rules that will bring us closer to compliance with U.S. pharmacopoeia standards. They are considering granting authority to somebody like the Commissioner of Health to, in the event that there is a precursor situation or a near miss or something that is an immediate threat to life or health, to be able to cease the sterile compounding operation. That currently is not a capability that we have. There's something called summary suspensions, and anybody can be summarily suspended from an activity that they are licensed to do. But summary suspensions take time. They require a type of legal procedure called due process that requires evidence, that requires a hearing, that can require days, if not several weeks. So that is something that we're encouraging. They've authorized an increase in fees to enable us to get an additional 3 inspectors of pharmacies. They've authorized more frequent inspections of higher hazard compounding pharmacies. And one of the things that my office will be doing, and actually are working on right now, is a creation of a commissioner's task force on compounding and board composition, so we can think about, over the next couple of years, what are the things that we need to do a better job of aligning the incentives and inspecting and regulating appropriately, so that this type of situation is less likely to occur. I think another important point to make, I think from 2006 to 2012, memory serves, we've done about 1,600 complaint inspections. The Board of Pharmacy has, the inspectors have in that time. And in that time, about 20 of those complaints were the result of a compounding complaint. About half of those were due to conditions that the inspectors saw themselves. And of those, five were dismissed for lack of evidence that there was a violation of procedure. Does that mean that the procedures were perfect and that merely following them would prevent an adverse event? No, it doesn't mean that. That's one of the things we need to look at. And in 15 of those cases, disciplinary action was taken. So something we all need to understand, and I think some folks in here actually read some of the reports on the New England Compounding Center. How many of you looked at those reports? They're available if you search them online. What you'll see was not just bad luck. It wasn't just momentary inattention. It was a series of a cascade of events that were not attended to, that led to tragic results. So this was not a situation where we had a mere momentary lapse in proper procedure. So we have to be very careful in the regulation that we do of the pharmacy industry, when hospital pharmacists are faced with a list of medications on a daily basis that they can't get, that are in national shortage, that potentially has the same or even worse consequences for population health than the event that we just reviewed tonight. Does that help?
No, yes, sir.
David?
You mentioned the index case was an Aspergillus species. Yeah. It's a little bit different, but it was not the same as many of the other cases. Was there a predominant organism, or was there a spectrum of aerosolized fungi?
It was a black mold called Exerohilum. It's ubiquitous in the environment, and I believe until this national outbreak, there had been 1 or 2 case reports in the world of patients who were immunocompromised having an infection with this particular fungal organism. The FDA and the CDC, in looking at the vials that we were able to provide for them, we and other states found a number of other contaminants, but some of them won't grow under the conditions that are found in the epidural space. There were some peripheral, in addition to the localized epidural infections, there were some peripheral joint infections, and so there was a spectrum of pathology, but the primary organism was Exerohilum.
Has everybody who's been injected with a lot that was felt to be contaminated been offered antifungals, or have they been observed?
No, it's based on symptomatology. These are not benign medications, and I believe we thought about the need for prophylaxis, if you will, or treatment prior to the onset of symptoms, and I believe that the consensus opinion on that was not the best course to take. Again, because of the toxicities and the substantial discomfort associated with taking these medications. The advice is to be vigilant, to look for symptoms like, and now, hopefully we won't find people that have worsening headaches or dizziness or loss of sphincter control. Some of the things that we saw with the early cases, we're mostly looking for is an increase in localized symptoms at the site of injection. And that should prompt an evaluation. There has been, in some cases, actually quite a few cases where there's been a concern, magnetic resonance imaging done to see if there's an epidural abscess that can be detected, and that's been followed up with a lumbar puncture. And if there are cells present, then there has been treatment provided. Some neurosurgeons have also gone in and drained abscesses. So you're getting kind of to the limits of my treatment knowledge on this, but there's a spectrum of care, and most of the people that have received these injections have not, fortunately, developed symptoms. But there, that the ongoing worry is that a few of them will. So unfortunately, nobody can entirely let their guard down because we really don't know, what their likelihood is. There seems to be, there will be more epi, I think, coming out in this as time goes on, but there seems to be some associated factors that may reduce the risk for individuals. The dose response aspect is really important, and to some degree, perhaps the mixing or the in-office compounding with certain anesthetic agents may turn out to have had a protective effect.
Maybe one more question?
I have one more answer.
Oh, yeah.
Thank you, Dr. Dreyzehner. My question is not specific to this outbreak, but it's about an issue that is clearly dear and near to your heart as it is to mine, which is primary prevention. And I always get disturbed, I guess, when people, perhaps truly so, indicate that primary prevention doesn't pay off, it won't reduce our healthcare expenditures, people will live longer and will incur additional expenses. And I was just interested in your view on that perspective.
Well, referencing my earlier example, ask the woman who's not been assaulted if primary prevention paid off. Ask the person who never smoked a cigarette and lived to be 90 if primary prevention paid off. So that's the problem with primary prevention, and that is when we're successful, nothing happens. It's hard to measure non-events. But I can tell you one of the things that we're actively working on in our department is to make the case for primary prevention. We have a state health planning agency that recently came over to our department from the Healthcare Financing Administration. It's not a large team, but it's a team of folks that help put together our state health plan. And that section is being charged with putting together a couple of small conferences, working with a nonprofit partner who's also very interested in this issue and knows we're interested in this issue, to bring people, particularly economists, around the table and help us describe both the cost avoided as well as the cost savings, as well as things like the productive person years of life saved as a result of non-engagement in harmful things. I mean, one of the things we know, in the developed world, what is most likely to cause death is not whether or not you have access to health care. That's about 10 to 15% of that equation. What's most likely to lead to demise are behavioral choices or exposures. Things like whether or not you smoke, whether you eat a healthy diet, whether or not you exercise. Those are the big ones. That's 40% of it. And we just, with the focus on care, if you hope for A and reward for B, you're going to get B. And behavioralists know this. It's been described in clever articles, and you know this because you asked me the question. In our society today, what we're really doing is, in some ways, now don't get me wrong, people need health care, okay, and there's plenty of us who would not be alive in this room right now had we not had the health care we needed at the moment that we needed it. And there are plenty of conditions for which there isn't known primary preventions. And so I don't want to discount the importance of health care, but we've come to a dramatic imbalance, And what we're creating, in my view, is almost an enablement of people to not really worry as much about keeping themselves in the kind of shape that they need to do the things that they love to do, to experience joy, to have the fullness of human potential, because we enable this mentality of, well, if I break, somebody can fix me. And so I think we're sending the wrong message by making it all about access to care. I think it's about access to health. I think it's about access to a fullness of human potential. I think it's about access to opportunity that breeds health, and prosperity that breeds health, and health that breeds prosperity. And if all we do is offer access to care as the answer, we're not going to get what it is we want. Thank you for that question.
Yeah. Well, one more round of applause for Dr. Dreyzehner. Normally, at the end of the leading voices, I have the opportunity to thank the speaker on behalf of the College of Public Health and the audience. But I think, John, it wouldn't be inappropriate tonight for me to thank you and the Department of Health on behalf of all the people of Tennessee for what you guys did with this meningitis outbreak, and in fact, all the people in the country.
Thank you.
And as always, we have some parting gifts. Tonight I see that they're
I already
wrapped.
have a No 39 pin.
Well, that's true. That's the most important thing. The gifts appear to be wrapped this evening, so I actually have no idea what they are, but I'm sure they'll be. And we don't have to offer to mail them home for you.
No, good.
But again, we would like to confer on you the title of honorary professor in the College of Public Health for your lecture tonight and all that you've done for us, both personally and professionally.
Thank you. It's an honor. Honor to be with you. Thank you.
This is the last Leading Voices for this semester. We have some very exciting things planned for next semester and beyond. But thank you all for being here tonight. Please make sure you've signed in. And if you want to get CME credit, you do have to fill out the appropriate paperwork. And thank you all very much. And for those of you online, thanks for watching. John, thanks again.